Brain Chat. I'm Dr. Mitzi Joy Williams, your board certified neurologist and fellowship trained multiple sclerosis specialist. My mission is to engage, educate, and empower those impacted by chronic neurologic conditions to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things brain health, wellness, self-advocacy, and how to care for your loved ones who are impacted by chronic neurologic conditions. Join me and my super friends and special guests as we get ready for the next episode. And most importantly, let's get nerdy.
Well, hello, everyone, and welcome to another episode of Brain Chat with the Nerdy Neurologist. I am Dr. Mitzi, the Nerdy Neurologist, and I am so excited to have not only one of my favorite neurologists, but my good friend, Dr. Annette Okai, with us today to talk about the diagnosis of MS and some of the new updates to the diagnostic criteria. Dr. Okai is a fellowship trained neuroimmunologist, and she is the director of neuroimmunology at the North Texas Institute of Neurology and Headache in Plano, Texas. Welcome, Dr.
Hi,
Okai.
Dr. Mitzi. It's wonderful to be here.
Awesome sauce. Well, you are no stranger to Brain Chat. So I
Yeah.
know everyone on Brain Chat knows Dr. Okai. And if you know Dr. Mitzi, you know Dr. Okai because we're twins, right? Of course. I want to talk a little bit about the diagnostic criteria of MS today. But before we get into that, just tell us a little bit about yourself and about your role as the director of neuroimmunology there in Plano.
Awesome. So, like you mentioned, I've been doing MS since we started together. It's
Hmm.
been a while, but yes, I'm fellowship trained, and currently I am director of neuroimmunology. What does that mean? I see all things MS and its cousins, all demyelinating and inflammatory disease of white matter in my clinic. I also am actively engaged in research for these diseases. So, ongoing clinical trials, mainly with investigational products, things coming to the market. So, yes, like all things MS on this show, I do all things MS and love it.
Awesome. Awesome,
Hmm.
awesome sauce. Well, it is always a pleasure to have you and always a pleasure to talk to you. So, I'm going to be picking your brain today. I want
Okay.
to circle back and talk about the diagnostic criteria for MS. So,
Yeah.
this has changed and evolved just over the course of our careers, but certainly over the
Yes.
past 20 or 30
Yeah.
years.
Hmm.
And so when people come in or people are concerned about symptoms, particularly if I have someone that comes and says, "Hey, Dr. Mitzi, I have a family member with MS and I have this tingling. How do I know if I have MS?" So let's just start at the very beginning. How do we diagnose? If someone comes in with symptoms that are concerning for MS, what do we do to help understand if that person has MS or if they don't have MS?
So fortunately for us, we are living in the golden days of MS. And
Hmm.
while MS is a devastating disease, we have made so much progress over the years because if we look back in the history of MS, they didn't have the machines like MRIs that we have
Hmm.
today to diagnose MS. Patients have to wait for symptoms or attacks to get diagnosed. The lumbar puncture was standard in those days. Fast forward to the early 90s, we got MRI, which greatly helped reduce the time to diagnosing MS because then we could look at the brain and look and see if there were lesions in there. But there was still this underlying theme that you have to have dissemination in time and space, and that was the buzzword for MS. You had
Hmm.
to have multiple relapses over multiple times
Hmm.
to get to the diagnosis of MS. And on MRI, you have to have lesions in multiple places, and some have to be active or new and forming over time to also get to the diagnosis of MS. But good thing we have criterion, right, to make this diagnosis a little bit easier to make this disease a little bit easier to
Yeah.
diagnose and make it uniform
Hmm.
across people, doctors, and places, so that
Yeah.
when someone comes into the office and say, I have numbness and tingling, Dr. Williams, how do I know that I have MS? You can say, well, let's go through your workup. We do a physical exam. First of all, we have to make sure that the clinical exam is conducted in a tailored in a way that we're getting to what MS looks like clinically. Then we do lab work and make sure we're not dealing with other inflammatory things, because autoimmune diseases and inflammatory diseases, they can share symptoms across the board, and so we don't have a specific symptom to say, well, my arm was tingling and it lasted this time, so it's MS. Lots of things can do that. And then
Right.
after the labs rule out those other mimics of MS, as we call them, then
Hmm.
we do an MRI. And on the MRI, we're looking for lesions that are in typical places for MS. I tell patients, there are lots of things that can cause white matter lesions
Hmm.
on your brain MRI, and depending on where they are, how they look, we put them in different buckets. And MS
Yeah.
has its own separate bucket, from high blood pressure and diabetes and migraines and all of that. So a complete history and physical lab work and MRI helps direct the diagnosis of MS.
Yeah. An MRI was really a game changer
It
because,
was,
yeah,
yes.
CT scans are used very frequently when someone comes in with acute or new neurologic symptoms, and
Yeah.
MS does not show up very well on a
Not like
CT
that.
scan.
Not
Yeah, and
like
so
that.
and many
Correct.
people would say, I went to the ER, they did a CAT scan, they said it looked normal, and I'm like, but
But
if we didn't do an MRI, we can't really diagnose MS. So I
yeah,
think that we're able to diagnose people a lot earlier, not only because of the MRI technology, but because of the accessibility of MRIs. So now we can get
exactly.
MRIs if you got a headache, if your eyes twitching, we can get an MRI for anything.
For
But it was
everything.
it was really hard to get an MRI when they first came out because they were
Yes.
so expensive. So,
Yeah.
there have been so many advances. So we talked about kind of the tests that we use to diagnose MS. So we use the clinical history, right? The history of symptoms. We use the physical exam. If we see abnormal things like,
Hmm.
reflexes that are a little bit too
Yeah.
jumpy, or, changes in your balance, when we make you walk or do the drunk driver's test, that plus
Yes.
the imaging and tests helps us to
Hmm.
diagnose MS.
Yeah.
Now,
And
once we make that,
sometimes,
go ahead, go
yeah,
ahead.
and sometimes we need a lumbar puncture,
Hmm.
whereas before lumbar punctures were standard.
Yeah,
Sometimes we need it, and now sometimes we do not. So that's
absolutely.
also ancillary test that we do as well.
Absolutely. Because the MRIs are so good now, right? So
Hmm.
we have different pictures that we can look at that tell us more about what's related to MS versus other things like stroke. And just like our cell phone cameras get updated and we can see a
Yes.
whole lot more than we could see when we had flip phones, I'm dating myself a little bit. Our MRI techniques get better and we can see more. And so we don't
Yes.
need the spinal taps quite as much because it's very
Exactly.
clear on
We're
the
seeing
MRI
those
images.
lesions in HD quality,
Absolutely,
or
absolutely.
4K.
HD.
Yeah,
4K,
4K
4K
HD.
lesions
Yes.
in 4K. All right,
Yes.
so thinking about the buckets, right? So once someone gets diagnosed, the next question is, well, Dr. Okai or Dr. Williams, what type of MS do I have? Tell us a
Yeah.
little bit about the traditional four buckets, and then I want to talk about how now we kind of split MS into two categories and not the four
Hmm.
distinct buckets.
All right. So yeah, I get that question a lot as
Mhm.
well. And so yeah, when we started, I mean, we are beginning to sound old, but we're not
I
really old.
know,
There
I
are some
know.
the advances have been so fast and so much that yeah, okay. But when we started, so MS was placed into categories. He had relapsing remitting
Mhm.
MS. You had relapse non-remitting MS. Then
Mm-hmm.
you had secondary progressive MS. Then you had primary progressive MS.
Mm-hmm.
But yeah, and there were these buckets that we placed people in, and at that time, I think it was really important because certain types of MS, and I say types because most people will say, "What stage do I have?" which is
Right.
different from types.
Mm-hmm.
Certain types of MS we had treatment for, and others we were left flailing. What are we going to do
Right.
with these patients? But and most of our medications were targeted at that time.
Mm-hmm.
And then as time went by, we realized that MS is not discrete. You
Right.
can't put it in one bucket, a person in one bucket as at a time. It's a continuum over
Right.
time.
Right.
So from those four buckets, we went to, oh, then let's put them into two big categories. One is relapsing and one is progressive because we
Mm-hmm.
recognize that the mechanism could be different and how we treat them could be. But then under relapsing, we have non active, and then we have active, and then progressive. We also have, you are relapsing progressive, and it's just
Mm-hmm.
became all these things. But what we realize is that how the patient look to us is important in also how we treat them.
Mm-hmm.
Okay, so primary progressive, yes, you have symptoms that begin, never remit, and there's this constant progression that occur. And
Mm-hmm.
then secondary progressive, you had relapsing first, and then you went into this progressive phase. You may have relapses, or they are not as severe or not as distinct as before. And then, of course, the relapse and remitting, you knew it. You relapse and you remit, and you relapse and you remit. And then
Right.
the secondary progressive, you had the non-active one where there may not be relapses, but you continue to progress. So then there's is further split down, non-active and then active secondary progressive.
Right.
But I think all of this is necessary, that as the signs progress, we are able to recognize that our treatment has to progress along with it. And I
Mm-hmm.
think helping us to put things in those categories has also made a difference in how we target our treatment to
Mm-hmm.
patients.
Absolutely.
And so now we are on the cusp of, a new treatment target for one type of MS, because we realize this is not, if all the medications that we have doesn't really have a profound effect on this phenotype of patients. So over
Mm-hmm.
time, we have evolved from thinking to four. Then we went, let's put it in two buckets. And then within those two buckets, we further subdivided, two
Mm-hmm.
here, two there. And now we know that someone doesn't stay in one bucket
Right.
for the length of their disease course. They
Mm-hmm.
move over time on this spectrum, and we have to move along with them.
Yeah.
Hmm.
And so this has been one of the most fascinating things to me about being a neurologist and being a neuroimmunologist is that our understanding of the disease
Hmm.
process has changed.
Hmm.
When these buckets were first created before we started working, they were
Yeah.
really based on how people looked, right? So when they
Hmm.
came to the clinic, either they were having those episodes where they were waking up and couldn't see out of one eye or getting
Hmm.
weak on one side, and then they get a little bit better, right? And that's relapsing remitting.
Hmm.
And then after a while, maybe 10 years, maybe 15 years,
15 years.
then we wouldn't see those episodes where they woke up.
Hmm.
It's just more, I got weaker. I'm not able to do the things that
Hmm.
I used to do. And that was more of the secondary progressive or, the primary progressive where they had that worsening over
Yeah.
time. And what we realize is that the progression and the relapses are happening At the same time, from the very
Yeah.
beginning, for
Yeah.
most people that we
Mm-hmm.
categorized as relapsing remitting, right? And so people can have progression that just happens slowly over time, or they can have progression related to their relapses. Because if you lose your vision in one eye and that
Mm-hmm.
vision doesn't come all the way back, you now have a new level of disability you didn't
Exactly.
have before that episode. So our
Yeah.
understanding is continuing to evolve. And I love our good friend Dr. Stevens Krieger's model, topographical model of MS. If
Yeah.
you want to Google that, you can. I don't have the slides to show you, but it's a really cool way of thinking about the different things that affect function with MS,
Yep.
meaning the symptoms that may happen in the beginning or the lesions that may occur, and the brain can kind of compensate for those. But
Mm-hmm.
over time, as you're less able to compensate, then you begin to see symptoms come out or get worse that
Yeah,
were
your
there under
reserve
the
goes
surface because
down.
your bounce back is not there. So your
Yeah,
neurological
your reserve is just going down. The way I
absolutely,
explain it to my patients is that
yeah,
you are withdrawing from your bank account, but you're
yes,
not depositing. So your
that's it,
reserve is going to go down, and to
absolutely.
recover from that, it's difficult when you're not depositing.
Absolutely, absolutely.
Mm-hmm.
So it's been really fascinating. So now let's get to this new diagnostic criteria. So we talked about the old way, we talked about the way that, our
Mm-hmm.
evolution of understanding of what's going on in the disease process has happened. But let's talk about this new diagnostic criteria, which, was recently published. We learned about it late last year at one of our big conferences, the ECTRIMS, or European
Mm-hmm.
Congress, related to MS treatment and research. And so let's talk about what we know now. So the diagnostic criteria, which has evolved over time, has really tried to see if we can, I think each evolution or revision has
Mm-hmm.
tried to see how early can we diagnose MS, right? Because
Exactly.
we want to catch people as early as possible, as normal as possible, because the treatments that we have don't fix what's already broken. They prevent new things from being broken,
Exactly.
so to
Mm-hmm.
speak. So right
Yeah.
now we don't have anything that fixes what's broken, but we're hoping eventually we will. But so we want to catch people earlier and early. So each time it's
Mm-hmm.
revised, it allows us to diagnose people earlier and earlier. So in the past, for you to have MS, you had to have an episode, an abnormal MRI, and we just had to wait for something else to happen to you.
Yeah.
That could be 6 months, it could be a year, it could be 5 years before we could diagnose you. Then the criteria changed and said, oh, well, it counts if your MRI changes. So you can have a symptom, and if we check an MRI in 3 months and there's a new spot, then that counts as, a new episode to diagnose you. And now, and then the revision after that, you could have a new spot and an old spot, and that would count. So talk about this dissemination in space and time, because time has been kind of the limiting factor in how we can diagnose people. So what's new about this dissemination in space and time that will
Yeah.
allow us to diagnose people earlier?
Yeah, and we all know that brain is time. Time is something that we do not have.
Hmm.
And with all the iterations of the diagnostic criteria that has gone on over the years, the aim is really, like you said, to diagnose early, and also to make sure that we are getting the right diagnosis so that
Right.
we treat properly. Like I said, so that
Absolutely.
if you are working in Atlanta, Texas, Kentucky, New York, California, we're all on the same page about the
Hmm.
diagnosis. So
Hmm.
when you're making these criteria, you have to make sure that the criteria is sensitive, that it catches a lot of people, and it's specific, that it catches the disease, that if you're fairly certain this is the disease that you're diagnosing and not other mimics. And with that, with this new criteria, what it has done, it has reduced the need for a dissemination in time. So instead of waiting months, weeks, years for something else to happen, you can make the criteria if you see certain things. So for your patient that comes in with numbness and tingling, Dr. Williams, and you know that numbness and tingling is typical of a demyelinating process, and you have an MRI that show active and non-active lesion, that is enough to fulfill dissemination in time
Mm-hmm.
and space overall to
Mm-hmm.
make the diagnosis. You don't have to do a lumbar puncture. You don't have to make wait for another attack to happen.
Mm-hmm.
And you can go and start patient on disease modifying therapy because they have fulfilled dissemination in time and space
Mm-hmm.
overall at that
Mm-hmm.
time. Okay,
Yeah.
so yeah, go ahead.
Yeah, and I think that's important. And so let's take it even a step back
Mm-hmm.
to radiologically or radiographically isolated syndrome, right? So we're
Great.
trying to
Yeah.
catch people early, right? We're
Mm-hmm.
getting MRIs on everybody. Let's
Yeah.
say somebody gets in a car accident or something happens, they're having headaches, they get an MRI and the MRI looks like MS, but they
Exactly
haven't had
like
a
MS.
symptom that's typical of MS.
Exactly like
So what
MS.
happens to that person?
And you know, before what I will do, Mitzi, I will say, wow, this is radiographic. You haven't had a symptom. Let's wait, repeat it, and see what's happening. But if you need to have a episode, you know,
Mhm.
we will wait initially, and then later on, when we saw that these patients will come back and they're having active lesions and they're
Mhm.
having non-active lesion behaving exactly like MS. For
Mhm.
some providers such as me, as me, I will go ahead and start treating because my
Mhm.
target is brain tissue. I need to preserve your reserve,
Mhm.
whatever you
I
have
like
to
that. Preserve your
your
reserve.
reserve. Yeah, and reduce the damage because once, as you said, once that happened, it we cannot get it back. We cannot repair properly. So
Mhm.
what this criteria does is that with radiographic isolated syndrome, and that is your MRI looks exactly like MS, but you have not had a clinical episode to go along with it. If we do other testing and the other biomarkers are in line with MS, we are then able to give you the diagnosis of MS and start treating
Mhm.
MS over
Mhm.
time.
Absolutely.
Before you
Right.
go and say, okay, a year from now, I have a significant relapse, I cannot see, or my
Yeah.
arms are weak. So, with
Yeah.
radiographic isolated syndrome, along with all the other biomarkers that are in place, we can now diagnose MS instead of just watching and waiting.
Yeah. You know, because
Hmm.
I think, as you said, time is brain.
Hmm.
And just because a lesion or spot does not cause you a symptom right now does not mean it won't cause trouble for you later on when that reserve
Exactly.
is decreasing and your bounce back or your ability to
Exactly.
compensate for
Exactly.
injury.
Hmm.
And so I think that that's extremely important, you know, and I
Hmm.
think about MS in the same way that people talk about hypertension. They talk about hypertension being the silent killer in
Yes.
terms of you may not feel anything, but it doesn't mean that there are not changes going on in your body
In
that
your
could cause you
kidneys,
to
your
one day have
eyes,
other
and
issues,
everything.
right?
Yeah.
Like your vision or cause you to have a heart attack or stroke, right? So we want to prevent those changes
Hmm.
before you have that catastrophic symptom that sends you to
Yes.
the hospital. So I thought that
Yes.
was a really important update to the diagnostic criteria.
I
Another
think
one that I
so
thought was
too.
very
Yeah.
interesting was optic neuritis. Now, optic neuritis is inflammation of the optic nerve. Now, when we think about MS, we know it affects the central nervous system, which includes the brain and spinal cord, but the optic nerves are part of the central nervous system. So it's the only
Yes.
cranial nerve that's part of the central nervous system. And so people can lose vision in one eye. They often say they feel like they have a film over their eye, or they may lose color vision in one
Hmm.
eye. And so those are typical symptoms of optic neuritis. Now, optic neuritis was not included in the diagnostic criteria, although we know it is a very common first symptom of MS. There was a whole
Up to
trial.
70%.
Yeah,
Up
there
to
was a whole trial called the
70%.
optic
Optic
neuritis
neuritis
treatment trial.
treatment trial.
Yeah,
Yes.
to help us understand who gets MS. But for some
Yes.
reason, it got left out of the
Chopped,
diagnostic criteria
chopped out,
until now.
gone.
So
Yeah.
optic neuritis is really important because we
Mm-hmm.
know it is a first symptom, and now it is officially included as one of the standard symptoms that we can use
Yeah.
to officially diagnose MS, which I think is important. I think we were doing it already, but I think it's
Yeah,
important for
I
that
think
to be up
yeah,
there.
we were doing it
We were doing it
already.
already. Yeah,
Yeah,
I mean, yeah,
exactly. But
absolutely.
yeah, so with the addition of optic neuritis, now we have the fifth area, topographical area, as it's called, that we can use to make the diagnosis. You know, there are different parts of the brain. We have four, and you can name them: ventricular, infratentorial, supratentorial, and juxtacortical. But someone come with optic neuritis and they didn't have those other three to four checked out
Mhm.
off, then oh no, we can't count that. But yeah, for episode that up to 70% go on to
Yeah,
develop MS, like we said before.
yeah.
I'm glad that it's now been added
Hmm.
as an area that you can count
Yes.
as a MS area to make the diagnosis of MS. But
Hmm.
we have been doing that, and it's now official, so we can
Yeah.
rest easy that we're still doing the right thing.
Right, because we were doing it right.
Yeah,
But now it's
exactly.
official. So we like it to
Hmm.
be official. So we'll
Yeah.
take it. All right,
Hmm.
now let's laser in for a few minutes on this MRI, right? So
Yes.
MRI is really kind of the mainstay. It is the
Mainstay.
main deal, the main ingredient, like that group from the 70s. I'm dating myself again, but is the main ingredient to us diagnosing MS. And there have been some updates to MRI and certain MRI changes
Yes.
being absolutely critical for us to diagnose because
Yes.
I'm sure you have seen, just as I have seen in my career, the folks who come in with symptoms and they're like, can I have MS and have a completely normal MRI? And so, right now, with the new
Hmm.
criteria, the answer to that is no.
No, you
You can,
must.
you must have
You
an
must.
abnormal MRI
MRI. Yes.
to diagnose multiple sclerosis. So let's talk a
Yeah.
little bit about that.
All right.
And yeah, go ahead.
Yeah, so I mean, as you said earlier in the show, MRI has been a game changer for
Mhm.
MS. So thankful that I'm practicing in this area with all the technology. And we
Yeah.
went from a 2 megapixel MRI, and I'm equating it to the camera again,
Hmm.
to 12 megapixel, and now we have HD and 4K.
Yeah.
Love it,
We had
right?
Polaroids. Those things were fuzzy. We had Polaroids.
um, and as we get higher and higher in magnification, we have the ability to see more things on MRI. And so, what
Mhm,
researchers had seen on MRI, in addition to the white spots,
mhm.
the lesions or the plaques, that whatever name we will want to call those, white matter abnormality, there are other things that pinpoint to the diagnosis of MS. One specifically is the central vein sign. All right, so the central vein sign, after a whole lot of research, it has now become specific to MS. And whoever thought MS will go back to the vascular theory, right? That now,
Mhm.
but we know that, when lymphocytes and all move, they move through the vasculature, and depending on that movement, where it gets stuck and all of that, you have changes that occur. But the central vein sign, depending on the sequence of the MRI that occur, and it's a specific sequence, and that's something that we need to discuss with our radiology colleagues when they're reading our report and looking at the susceptibility weighted sequences,
Right.
if a central vein sign is present, because
Mhm.
that is highly, highly correlated to MS. Another thing that we see on MRI is paramagnetic rim lesions,
Mm-hmm.
and this is new and I think very exciting because when we talk about the types of MS that we have now,
Mm-hmm.
we equate paramagnetic lesion to one of those buckets.
Mm-hmm.
People that are progressing
Yeah.
independent of relapses. This is something that when we see how can we address that with our disease modifying therapy.
Mm-hmm.
So we can go a little bit more into it, but the central vein sign and the paramagnetic rim lesions
Mm-hmm.
were the newest addition to
Mm-hmm.
the MRI
Mm-hmm.
definition in this revision of the diagnostic criteria when it
Absolutely.
comes to MS.
Absolutely. And then there are a
Mhm.
couple of additional biomarkers. So, biomarkers are tools that we use, whether they
Mhm.
are from blood draws, whether it is from your spinal fluid, whether it is the MRI. These are
Mhm.
tools that we use to tell us about either diagnosing disease, about the state of the disease, about
Yep.
progression of the disease. So, those are two important new mentions in terms of MRI. Are there
Mhm.
any other biomarkers or markers that are mentioned in the new diagnostic criteria? For instance, kappa free light
Yes, so
chains,
kappa light,
NFL.
yeah, kappa light chains is mentioned in there, and CSF. If you're doing CSF, that's one way you can measure it. I think it's the most accurate measure of that. NFL on is also
And not
mentioned,
the National Football League
not the
NFL.
National Football League. It's
Neurofilament
neurofilament
light
light
chain. It's not
chains.
that exciting.
Yes. For that is more specific in the serum versus the CSF. And
Hmm.
and now even that test is nationally accepted as a marker and is
Hmm.
commercially available
Hmm.
to order that you can look for in MS patients and other neurological disorders, but it's also elevated in MS that you can follow patient longitudinally over
Hmm.
time as
Hmm.
well. It was used. It was and is used heavily in clinical trials as
Hmm.
well. So it's good to see that it has now left the trials and coming to the exam room
To the real
and
world.
how we approach our patient with MS. But yeah, it's now available to order just from your local lab with when you're diagnosing and monitoring your patients over
Hmm.
time.
Hmm.
Mhm.
Well, Dr. Okai, this has been an exciting conversation. I
I
say
know we could
repeatedly,
go on and
we
on.
could, we could, but we're not going to. Um,
Okay,
you
okay.
know,
Hmm.
but I think this is so exciting because when I entered this field, I knew that I would be a part of a revolution in medicine, that we were on the cutting
Yes,
edge and
yes,
that
yes.
things would change drastically during the course of my career. And I'm so
Hmm.
excited, even though to people listening, depending on how scientific you are or if you're involved in the medical field or not, some of it may sound like a little bit of mumbo jumbo, but all of this enables us and those who are treating MS and diagnosing it to diagnose people, identify them earlier. And this is just really exciting because
It is very exciting, very
ultimately we
exciting.
want a cure. We're not there yet, but certainly catching people really early and stopping further damage to their brain and spinal cord
Yes,
is a
and
sure good runner up
it
to
sure
that cure.
is, and making them live their lives and attain their
Absolutely.
goals,
Absolutely.
and even their lifespan is prolonged because the
Yeah.
complications that come with prolonged disease is just amazing,
Yeah.
amazing where we are in this. We still have a long way to go, and we
We do.
recognize that,
We do.
but it's just good to see that we are moving in the right direction.
Absolutely. I think ultimately the new frontier, the next big goal, because many of our treatments, which we're not going to go into specifics today, do focus on inflammation and that relapsing part of the disease.
Mm-hmm.
We certainly have seen the first treatment for primary progressive MS,
Yeah.
which I did not know that I would see. And there are certainly multiple other treatments that are looking at targeting progression. I
Mm-hmm.
think that something that focuses on progression is going to be a next big leap. And then
Yeah.
ultimately, we love something that repairs.
Yes.
So we're
Yes.
not there yet,
Mm-hmm.
but people are diligently working on it. Our colleagues are diligently doing this work, and we're also doing research to try to better understand, to make sure that we can treat people as effectively and as early as possible. Any parting thoughts for you, Dr. Okai, for that person that's out there, that is seeking a diagnosis, not sure if they have MS? Do you have any advice for them?
Well, for someone who's not sure, seeking a diagnosis, I will always tell you, be your own advocate.
Mm-hmm.
Ask questions and make sure that you are getting the care, the testing, and all that you need, and don't just sit and something's going on,
Right.
but you're being told one thing and there's nothing you can do. So be an advocate for yourself. Make sure that you have a physician who's listening to you and
Mm-hmm.
who's willing to go the extra mile, because sometimes making a diagnosis takes someone going the extra mile. We
Absolutely.
now have new ways to make the diagnosis of MS. We don't have to stick to the old ways, and things will continue to improve. For those who are newly diagnosed, I will say, while having a chronic disease diagnosis is not ideal, but we have come so far, and making sure that you start and stay on disease modifying therapy to help you achieve your goals in life, and continue living life to the fullest. And for people already living with the disease, veterans as we call it, there is still hope, because the next frontier is
Yeah,
here. It
absolutely.
is here, and we're excited to be part of that and to share it with the greater MS community.
Amazing. Well, I could not summarize or say it better than that, Dr. Okai.
Mhm.
Thank you so much for coming to hang out with me on Brain Chat.
It
I look
was
forward to
lovely
us.
hanging out with you.
Yes, I look forward to us recording an in-person episode soon. Stay
All
tuned for
right.
that, Brain Chat
Yes.
friends and Nerdy
Okay.
Neurology Nation. We also want to thank our sponsor, the National MS Society, and I want to thank each and every person that took the time to listen to or watch this video. I hope that it encourages you. I hope that you learn something from it, and I hope that you take something back to ask your doctor and your healthcare team about at your next visit. Thank you so much, guys, and have a wonderful day. We'll see you again in 2 weeks. Thank you, Dr. Okai.
Thank you.